Hello, everybody. I am Waqar Ahmed, interventional cardiologist in Jeddah, Saudi Arabia. It gives me great pleasure to introduce Dr. Didier Tchéché from Toulouse, who's an interventional cardiologist, very well known from all our meetings at EuroPCR. This year, I was not able to attend, but we are now talking to him via Eurointervention. So I thank Eurointervention for this opportunity. Didier presented a new study on bicuspid aortic valve intervention with TAVR. And I will let Didier introduce the study, and then we will discuss it. Didier.
Okay, thank you very much. So it's a great pleasure to discuss BIVOLUTX for Eurointervention. And so the idea of BIVOLUTX was to try to gather data, more contemporary data on the outcomes post-TAVI in bicuspid aortic valves. So we know that most of the data that we have so far comes from derived from retrospective registries with a quite selected population. So we try to enroll non-selected patients or at less selected as possible cohort of patients. So across 14 centers in Europe and Canada, among 3,000 and close to 800 patients, 5% at bicuspid. The enrollment period was between May 18 and December 19. And so among these 200 patients, 152 were deemed suitable for TAVI with the Evolut Pro platform. That was the most contemporary iteration of the Evolut device at that time during the enrollment period. So 152 patients. And finally, we considered 149 patients for enrollment inclusion within the BIVOLUTX registry. So it was a prospective registry with a quite academic, robust, a single device, echo core lab, CT core lab, clinical event committee, and the centers had to pre-declare their sizing methodology before treating the patients. And the outcomes were, the primary outcome was valve performance that was defined as either a mean gradient below 20 millimeters of mercury post-TAVI at 30 days, or a peak velocity less than 3 meters per second, and no moderate to severe paravalvular regurgitations. There were also a couple of secondary endpoints, the first one being 1 year all-cause and cardiovascular mortality, the second one being severe patient prosthesis mismatch, and the third one being the ellipticity index as assessed by MSCT post-procedure.
Okay, Didier. So this was the study. Before we get into the study, I have one question, which is TAVI or TAVR is always the model for introducing new devices. TAVI was never let out until the randomized clinical trials were done, the major ones. We started with the high-risk patients, then the moderate-risk patients, and then the low-risk patients before it was allowed in hands of general interventional cardiology community. Yet bicuspid aortic valve TAVI has never been tested against surgery. And that's many of my surgical colleagues and surgeons I know always say that. It's like, why haven't we, or the interventional community, done a randomized controlled trial versus surgical valve replacement instead of these registries, either prospective or retrospective?
So that's a very important issue that you raise, and ultimately and ideally a randomized trial comparing TAVI to surgery in bicuspid aortic valves, aortic stenosis would be perfect. But we don't have the same degree of knowledge for tricuspid and bicuspid aortic valves, and we are still understanding more and more about who is a good candidate for transcatheter intervention with a bicuspid phenotype. Can we treat all type of bicuspid aortic valves? We have signals from these retrospective registries telling us that if you combine a severe calcification at the level of the leaflets and a raphe, the outcomes could be poor for the patients with an increased mortality. So it tells us that we need to select the appropriate patients for TAVI in bicuspid aortic valves. The day we have understood, we will have understood everything about patient selection, sizing, all the technical procedural issues, and how to follow up these patients, we will be ready for a randomized trial against surgery.
Okay, that's good. Now, getting into the study itself, you mentioned it very quickly that every center had to say how their CT sizing was done. So pre-procedural preparation, how is the CT sizing different in the bicuspid valve versus the general tricuspid valve?
So once again, you are touching a very central element of the procedure. Before the procedure, we need to size and select the device type and dimension. So CT scan is the gold standard. With that CT scroll technique, you start from the aortic annulus and then you scroll up and down to better understand the distribution of the leaflets, the extent of calcium, because it tells us about the inherent risk of the procedure for the patient. And there are two main strategies that have been tested in BIVOLUTX: an annular-based strategy for all the patients, and 50% of the centers use the annular-based sizing strategy, or a combination of the annular dimension and some supra-annular elements, whether it be the commissure to commissure distance, as it was proposed by the BIVOLUTX Registry, or a supra-annular tracing. And what we saw in our registry is that independently of the type of methodology, sizing methodology that you utilize, the outcomes are the same. So an annular-based sizing methodology strategy works for bicuspid aortic valves, and understanding about the supraannular configuration of the landing zone is more is aiming at preventing complications, avoiding any damage to the aortic root. So it's more about that.
Okay, so and staying within the procedure itself, was the valve preparation, the native valve preparation, any different? I see in your paper, and there will be a link to this paper in the here, and that will be that lot more pre-dilatation with balloon and a lot more post-dilatation balloons were done. So can we comment on that?
Exactly. So this is a contemporary technique. So what we can, how can we summarize that? First, it's a little bit more challenging to cross the aortic valve. So, most of the time we need to utilize hydrophilic wires. From the registry, the pre-dilatation rate was very high. So it's a quite systematic pre-dilatation policy for bicuspid aortic valves. And the center is tending to use the minor axis of the annulus at baseline just to decide on the balloon size for pre-dilatation. This was a self-expanding platform, repositionable, that was utilized, and that repositionability, reshiftability of the device was utilized in 35% of the patients, so quite frequent. Post-dilatation was also a key element, a key procedural aspect. 55% of the patients had post-dilatation, just to make sure that it wasn't really for the gradients, it was more for circularity and a better expansion of the stent frame.
Okay, so do you recommend now for BAV routine pre-dilatation?
Definitely. And whether you utilize, the centers are going to use a balloon expandable platform or a self-expanding one, it's better to pre-dilate. And this is going to provide you additional elements in terms of understanding the overall risk of the patient, because you can also understand what is going to be the movement of the calcium and the risk for the coronaries or even for the sinus of Valsalva itself.
Okay. So the technical success was amazing. So can we now comment on the 30-day and 1-year outcome for these? We see a lot of events, so I would love to hear the details and comments on this.
Yeah, so the main take-homes from BIVOLUTX is the first, this remains bicuspid aortic valves and not tricuspid aortic valves, and they are more complex. So this correlates to a higher event rates as compared to what we see with tricuspid aortic valves. And we had more patients, 3 patients required 2 devices to get a perfect sealing, so of the aortic annulus. So we had a 1-year mortality that was 11%, and that tells us that the risk profile of the patient plays a role, but as well as the bicuspid phenotype itself and the amount of calcification. The pacemaker rate was still 25%, and that was certainly a combination of this post-dilatation policy, a little bit more aggressive than what we do for tricuspid aortic valves. stroke rate, disabling stroke rate was also higher than what we see in a tricuspid patient. So I would say that one of the conclusions is first that we need to work on a patient selection. It was less selected in BIVOLUTX, so more closer to a all-comers population. Better understand who is going to get a good outcome post-TAVI in bicuspid aortic valves. Second, potential systematic use of cerebral protection devices, because the stroke rate, the disabling stroke rate was higher. And these are the elements that we need to improve in the future, just to be comparable to surgery.
I think that's an excellent point. It would be interesting to see if a study can be done exclusively to bicuspid aortic valves and systemic cerebral protection, if that will be a very positive study or not, as we know that the device is available, but the evidence still is not that clear. So finally, coming to 2 points is, after all your experience with the BAVs and this registry, one, is there a particular sievert type more suitable for TAVR, and is there a particular type you would say, no, patient is, even if it's moderate risk for surgery, surgery is better?
If we analyze more precisely the CT phenotype of the bicuspid aortic valves, type 1 left-right was the most frequent one, 72% of the cases, followed by a type 0, about 10% of our cohort, and type 2 was really rare. So all the conclusions from the BIVOLUTX with the overall good clinical outcomes, excellent valve performance with a mean EOA above 2 centimeters square and mid gradient less than 8 on average. All these conclusions can only be applied to type 1 and type 0. So we know that type 1, type 0 can treat them quite safely. Type 2, we don't have enough data just to support this systematic utilization of TAVI in this phenotype. I would say that the more the patient is calcified, particularly if it's combined to calcification of the raphe, the higher the procedural risk is. So the more cautious we should be in terms of sizing and procedural steps. So we still need to work together with the surgical community as a heart team to perfectly identify the good candidates for TAVI.
Okay, so finally, so what has, where do we go from here? What will be the next steps in this field in terms of bicuspid TAVI, especially worldwide, Asian patients, the non-Caucasian patients?
So all the data accumulated, gathered are quite reassuring. So we're going to face more lower risk and younger patients with a greater proportion of bicuspid phenotype. So we know that we can safely treat these patients. So the experience is going to grow worldwide for sure. So I would say three perspectives from my part. The first one, as we said, we need a randomized trial against surgery in a precisely defined population to clearly better understand the outcomes. Second, potentially a head-to-head comparison of devices, balloon expandable platforms and self-expanding platforms in this phenotype, in this type of patients, could be of interest for us and our patients, and that's really key. If there is superiority of one device, that's going to be beneficial for the patients. And at last, potentially we need a dedicated device for bicuspid, whether it be a new TAVI device or leaflet preparation devices. We're going to see that in the future. Excellent.
Thank you very much, Didier, for your time. And we'd like to conclude this now. And I would tell our audience, please subscribe to our platforms on Eurointervention Twitter and Instagram and LinkedIn. Thank you very much.
Thank you very much for having me.
Thank you.